can start. Ma'am, start here, ma'am.
Okay. A very good afternoon to all. Today we gather here for learning about a very important topic, that is retinopathy of prematurity. Let me share my screen here. Can you see full screen?
Ma'am.
Okay. So going ahead, retinopathy of prematurity. Now, what do we know? As I'm talking to most of the pediatricians, let's go through the eye anatomy first. Now, in the eye, the innermost layer of the eye is known as the retina. And this is the one which is a dynamic layer which takes time to start building up after the birth of the child. Now, if this globe is, so imagine globe of the earth put out as a map. So if the globe is opened up and put, this is how we see it. So when we look inside the eye, this is how we see the retina. This is the optic nerve and this is the macula, where the sensory layer is known as fovea. Now, timing of vascularization is very typical, that by 16 weeks gestational period, only the posterior pole, that is the optic disc and a little bit of macula develops. By say 32 weeks, the zone 2 develops quite well. And the development of the entire retina takes place by 36 to 40 weeks. So even sometimes in a full-term baby, the retinal development may happen post-delivery. Now, considering a premature birth being very early, say 28 weeks or 26 weeks, 24 weeks, imagine there's so much of the retina which is left to develop. Now, retinopathy of prematurity is, as the name suggests, it's an apathy. So it's an apathy of the retina. It is a potentially blinding disorder, and it's a dynamic time-bound disease, which means that if there is delay in identification and treatment, then this can lead to permanent blindness. And it is something which you cannot rule out on a newborn eye screening, which means that at birth, if you're doing an eye examination, you will not be able to detect it because it is never present at birth and develops later. Now, the term came very early, say 1940s and 50s, when they started having oxygenation for the babies. That is when they realized that many of these babies are becoming blind. And the term was actually retrolental fibroplasia, which means retro means behind, and behind the lens, development of fibrous retinal tissue was known as retrolental fibroplasia. And Chadwell was in 1950s. He was the one who was responsible for identifying that there is some correlation between oxygen and ROP. Now, mind you, there were no pulse oximeters also at that time. So what they used to do is they would monitor the retinal vessels and look for vasoconstriction to reduce the oxygen percentage going to a child. So initially they were giving 100% oxygen to all children, and slowly they realized that some of them may not require it, and they're actually getting a lot of brain injuries, lung injuries, as well as eye injuries in the form of ROP. And therefore they tried to monitor the vessel dilatation or constriction, and if they found that the vessels were constricted, which means that they were going into spasm, they reduce the oxygen concentrations. And that is how they used to monitor in those times. Now, let's go to the etiology of this peculiar disease. Now, this disease is very much a disease of prematurity and low birth weight. Now, when we start these babies on supplemental oxygen, at this stage, now retinal vessels are immature. They stop developing because they get oxygen from somewhere else. So they go into a vaso-obliteration phase where they drop out the development of new vessels and are happily enjoying the high oxygen supply which is coming. But slowly, as the child grows and the oxygen requirement of the body goes down, we start lowering the oxygen systemically, and that is when this hungry retina does not know what to do. So now it goes into a vasoproliferative phase where new vessels start getting built up. They have increased of VEGF and all the other vaso factors like IGF and VEGF increase in the body, and then there is a lot of neovascular proliferation. Now, new vessels anywhere in our body are very, very sensitive, very friable, and therefore they are the one which causes leakage, bleeding, and even vasoproliferation, causing tractional retinal detachment, which means pull on the back of the retina and permanent vision problems. So typically in the vaso-obliteration phase, if you see there is increase of this oxidative damage product. So free radicals increase, peroxidation increases, and you have decrease in VEGF. So there is a drop in VEGF because you don't require new vessels. So their body consider it as a signal to drop the VEGF and drop the IGF-1. And this is what creates the problem. Slowly, when the VEGF comes back, it comes back threefold. Increase of VEGF, increase of EPO, increase of IGF-1 factor happens, which causes vasoproliferation. So what they say is that instead of treating in the second phase of ROP, it is even better if we recognize in the first phase of ROP, and now newer modalities of treatment like antioxidants, vitamin E, are being studied, where if given even the omega-3 fatty acids, these are the ones which can prevent vaso-obliteration, allow for good vessel growth to happen, which will prevent your phase 2 ROP, which definitely requires the laser. So, where are we standing now? Prematurity is almost 13 per 1,000 live births, according to statistics. India stands the highest in the world. 20% of the total premature babies are born in our country. We have almost 3.5 million annually born, and we have unfortunate huge amount, 18,000 children all over the world go blind each year with this blinding disease. Now, where are we? In India, we still have poor ANC services. We have 58% of women in our country who still do not take at least 4 antenatal checks. So with generalized poor health of women, we have more of premature births happening and poor maternal health causing even worse ROP. Now, in the UK, when there were the screening guidelines, they screened and said that less than 31 weeks and less than 1,500 grams is whom we want to screen for ROP. So very small babies. But in India, we kept seeing in the last 2 decades a lot of ROP in even bigger babies. So now our screening guidelines are very different from the Western world, and we'll share that as the talk goes ahead. This is what is disturbing most of the pediatricians as well as ophthalmologists, where they have multiple cases of litigations happening against eye hospitals, against general pediatric hospitals in the last decade or so. And these are the ones which are waking everybody up again to the medico-legal aspects of treatment of ROP. Sustainable development goals, which are set up by the UN, keep infant mortality rate into a very important consideration for the country's development. And we are happy to share here that India's infant mortality rate has actually gone down. In 2010, it reduced to 28 per 1,000 births. But with this reduction in your infant mortality rate, we are saving more babies, which is a good sign. But here we also see we have increased babies who are at risk of ROP. And 15% of the eligible screen babies actually develop sight-threatening ROP. So we have a huge burden on our country as of today. it is very, very imperative for all the SNCUs and the NICUs in the country to integrate ROP services in their portfolio, because ROP is a disease where the child gets almost at discharge. So systemically, the child is quite good, but on discharge, there is this vision threatening problem. And many of our SNCUs and NICUs, as we know, are in the district headquarters or in the major cities. And these children are going to go back to their hometowns and villages and not be seen by an eye doctor, which will cause permanent blindness. Now, let's go to the etiology of this disease and what's happening here. So, like I said, there is this vaso-obliterative phase where the excess of oxygen that you're giving to the child actually acts like a signal to relax, where it stops developing the retina. And then when the oxygen demand actually goes up in the retina, so there is a hypoxia, there is actually a good oxygen supply happening in the body because of lung functioning again. But the eye metabolism is quite active at this stage, and it's really hungry for oxygen, and it goes into a hypoxia. And this hypoxia stimulates the IGF factor 1 and the VEGF. And once they start coming into the system, there is vasoproliferation. So, like I said, there are a lot of newer modalities which can be thought of, including something called stem cell therapy. Now, they have studied the genetics of children who are getting severe ROP, and here they found out that those who are having very high worse ROP, high ROP, these are the ones who are actually having some genetic mutations. And if stem cell therapy can be studied in these children, they would go a long way to prevent permanent blindness. So antioxidants, anti-inflammatory markers, your omega-3 fatty acids, these are the ones which are being studied now to work as a preventive model against the disease. Now, what we actually know, what are the real high-risk factors? Exposure to excessive oxygen, sepsis, intraventricular bleed, blood transfusions done very early in life, and poor weight gain. These are definite known high-risk factors for developing ROP. Now, how do we prevent ROP? Can we prevent preterm deliveries? I think it's a difficult question, but in our country where there is still very poor ANC services, we can definitely do something about it, increase the antenatal care for these young mothers. Antenatal steroids in the mothers where we are suspecting they will go for a preterm labor, giving a proper antenatal steroids for lung development is mandatory. Now, prevent preterm delivery as much as possible. Make sure that these high-risk mothers do not deliver in services where there are no NICUs. And therefore, NICU care deliveries is an absolute must. Better assisted reproductive regulations have come into place which prevent inoculation of more than one egg, and therefore prevent multi or twin and triplet deliveries, which are more likely to go for preterm labors. How can you monitor the oxygen? Now, this is a question which is being wonderfully tackled by all our neonatologists on the panel. But what we know for sure is more than 95% of oxygen can cause, so SpO2 of more than 95% can cause retinal vessel damage. But we are working in a zone where you can't really take off oxygen, because then there is more of lung and brain damage. So to help all the organs develop well, they have kind of formulated a cutoff to put all your monitors on this alarm, where it rocks anywhere between 89 to 94%. So the alarm should go off if below or above this value. And taking off ventilators, using CPAP where possible, using oxygen blenders where possible, trying to reduce the concentration of oxygen going to these babies is an absolute must. Preventing ROP in the golden hour. Now, there is this concept that in the delivery room itself, we can do few things which can prevent ROP. We can use bag mask ventilation with 30% oxygen. We can use, like I said, oxygen blenders to mix room air so that the concentration of oxygen going to these babies is down. We can keep these babies warm, and it has been known as a fact that keeping the temperatures of these babies warm actually helps with the retinal development too. Delayed umbilical cord clamping has also been known to prevent intraventricular hemorrhages as well as the NEC, and you have lesser risk of blood transfusion if you don't have these diseases, and therefore you are preventing early blood transfusion and therefore preventing ROP. And there is this points of care, POINTS. P is for pain control. So any baby who is in too much pain is going to cry more, and increased oxygen demand happens then, and therefore the hungry retina and therefore the ROP. Oxygen management, like we've already touched. I is for infection control. Sepsis is a very important factor which can cause ROP. So good hand washing, minimal handling, minimal cross handling, having a good nurse to patient ratio in ICUs will help a long way. N is nutrition, and breast milk has to be again and again, the role of breast milk in preventing all kinds of diseases is coming more and more, including ROP, the omega-3 fatty acids, and a lot of antioxidants which cross and go into the breast milk cannot be artificially created, and therefore having breast bank like what KIMS Cuddles already has goes a long way in helping these babies and preventing ROP. T is temperature control, and S is supportive care. Kangaroo mother care is known to prevent even ROP. So anemia, and a very, very, very important factor now is that our children cannot be anemic. So if we see at third week, fourth week, the patient has been seen, there is ROP developing. And if the hemoglobin is less than 10, then here we insist that the child gets a blood transfusion, and we try to keep the hemoglobin above 10, especially those with aggressive posterior ROPs and who are higher grades of ROP, definitely get hemoglobin done in these children and keep the anemia at bay. Now, what are we looking at if we are not doing the ROP screening, or if we go wrong in this screening and management? We're looking at cataracts, we're looking at retinal detachments, high myopia, glaucoma, amblyopia, which means lazy eye, and basically a child who is needlessly blind for life. So a task force has been created in India with neonatal care experts, eye care experts, public experts, and all our policy managers. And quality of NICU is going to be assessed not only by your mortality rates, but also by the incidence of ROP. So ROP itself is a very important factor to determine the quality of the neonatal care in the NICU. And we would be happy to share that the incidence of ROP so far in the last 5 to 6 years in the KIMS Cuddles NICU is almost less than 1%. So that shows the level of quality care in the NICU. Now, these are certain guidelines that have been created by this task force, and it has been published in Indian Journal of Ophthalmology. And this is almost all that I told you so far, and how to treat is what I will discuss later. Now, what are your screening guidelines in India? Like I told you, in India, we are seeing ROP in quite bigger babies. So the gestational age of less than equal to 34 weeks and birth weight of less than equal to 2 kgs is when we should be screening for ROP. If the gestational age is more than 34 weeks, but there are other risk factors like we discussed, cardiorespiratory support was required, prolonged ventilator, sepsis, blood transfusions, chronic lung disease, intraventricular hemorrhage, or poor post-birth weight gain. These are the babies that you should be screening for ROP. Now, when do we screen? The idea is to screen by third to fourth week of life. So all the babies who are born after 28 weeks of gestation, try to screen these children between 3 to 4 weeks of life. But if the child is very young, born less than 28 weeks, less than 1200 grams, then these are the babies whom we should screen between 2 to 3 weeks of life. How do you screen? It requires coordination between the NICU staff, the nurses, and the doctors, as well as the ophthalmologist. And just instilling these dilating eye drops, 0.5% tropicamide with 2.5% phenylephrine drops, 2 to 3 times instillation every 10 minutes, and should be done 45 minutes prior to the check. And most of us, we use indirect ophthalmoscopes with a 20D lens. And this gives you a very good picture of both the eyes on a proper basis. And there are other methods now like RedCam. Now, this is a screening method where you do not require doctors on the field. We train vision technicians, and they go around in all the NICUs and use teleophthalmology to spread to send the images. Like you see on the images on the right, these are really good images which help you kind of grade the level of ROP sitting in your own hospitals, and which patient requires laser and which requires an injection and all can be decided by the doctor offshore. Now let us go to the nomenclature of ROP, which is quite confusing for a lot of us. So let's get one thing at a time. First of all, what you will hear in this is zones. Now there are 3 zones when we check the retina: zone 1, zone 2, and zone 3. For ease, just remember that zone 1 ROP is the worst because it is very close to the optic nerve and the macula, which is the main vision driving force of the eye. So zone 1 is where this is the disc, and this is the macula, just for representation, and double of this distance will be circumference, will be zone 1. Then the distance till the nasal ora serrata. So ora serrata is the edge of the retina. So the nasal ora serrata, if you draw a circle, is the zone 2, and whatever remains now is the zone 3. So zone 1 is the worst. And this is how, if we again closed the retina, this is how it would look if it is in the center, if it is in the periphery. So zone 1, zone 2, and zone 3. Going ahead, what you will really listen more is stages. Now, what is stages? Stages is when the retina, so you have a vascularized retina and you have an avascular retina. Now, there is a fight in between these two because the avascular retina is hungry and there are vessels on the vascular side. So it wants to eat up all of this oxygen fast. And so in that fight, there are this region which develops, which we call stage. So this is stage 1. I don't know how much you can see here, but there is a faint line between the developed, that is the vascular, and the avascular retina. So if you have a line like what is seen here, a demarcation line, that is a stage 1. Stage 2 is when this line thickens and it forms a ridge. And if you see this is a little thicker than your stage 1 line. This is a ridge. Then you have stage 3, where this ridge becomes thicker and it starts having extra retinal proliferation. So you have a vitreous cavity just above this retina in the closed globe, and if vessels start developing towards the vitreous cavity, that is known as extra retinal proliferation. And when this vessel proliferation happens, that is stage 3, and that is where your danger starts, because from that area the retina can completely pull off. And that is what happens in stage 4, where you have the retina pulled off. So this is a retinal detachment, where still, so this is the optic disc and macula is here. Macula is still intact, so we call it as stage 4A. But if your macula is also off, then this is known as stage 4B. And closed funnel retinal detachment. So completely your retina is off the globe, and that is stage 5, which is complete blindness. So there are other terms which you will hear, which is like this is plus disease. Now, plus disease here is where your vessels, so arteries as well as veins, are all looking the same. Normally arteries are narrower, veins are bigger. But here you have dilated, tortuous, very, very thick vessels developing, which we call as plus disease. And this is a sign that the eye is hungry. And pre-plus is this, where some quadrant you might have a little vessel dilatation, but it's not there in all the quadrants. If it's a vessel dilatation and tortuosity is there in 2 or more quadrants, then it is known as plus disease. So this here is a pre-plus disease. Now, APROP, this terminology, aggressive posterior ROP, or now we call it as aggressive ROP, not even posterior. Posterior is because it is near to the disc and macula, but this ROP is very different, which means that it does not have stages. It does not go from stage 1 to 2 to 3 to 4 to 5. It will not give you time. It is going to detach the retina within days. And therefore, identifying aggressive posterior ROP and treating it at the right time is absolutely imperative. So here, very typically, you see these kind of vascular looping and shunt. So like seen here, these vessels, they all join to each other. They form this network and they're going to detach the retina from that network. So it's a very strong network of vessels. Vascular looping and shunting is an absolute ominous sign. Next is a hybrid ROP, where you will feel this is APROP, but there will be a stage also. They might be stage 1 and 2. And therefore, these are again to be treated like an aggressive ROP and treated immediately. Third thing that is usually shown when we write or we quantify the ROP is extent. How many clock hours are involved? So if you put both the eyes together and draw a clock, so usually we would be demonstrating like this. So this is the ICROP classification, where all of us are mandated to actually record the ROP in this manner, where you will say zone, you will say stage, you will say how many clock hours are involved. And if you see here, the right eye 3 o'clock will be nasal, but the left eye 3 o'clock will be temporal. So just put the eye and the clock and write accordingly. Now, this is the ROP evaluation card. Again, it's mandatory to give something to the parents so that if they are changing places, cities, hospitals, there is a record for everybody who is involved in the care of the child to know that ROP evaluation was done. These were the findings. This was the treatment, and this is how it's going to go on. Giving your next review date is also very important. And you should also have a data with the child's name, number, so that from the doctor's side also, we do a call back to these patients so that ROP is not forgotten. Now, there are other terms. This is known, this was from the ETROP classification, where we have threshold ROP. Now, what is threshold ROP? So as the name suggests, threshold is that means you are not going to have a control now. It has reached a threshold. So this is the ROP which definitely requires to be treated. These are stage 3 ROP in zone 1 or 2. Look, I said zone 1 is going to be the most dangerous. So zone 1 or 2, stage 3 with a plus disease involving many clock hours is definitely the one you have to treat. There's no doubt about it. The problem or the confusion comes where it is pre-threshold. Now, in pre-threshold also, it has been divided as type 1, which is high-risk ROP, type 2, which is low-risk ROP. Now, type 1 ROP is again the same, like zone 1, any stage with plus disease. Zone 1, stage 3, even without a plus, and zone 2, stage 2 or 3 with a plus disease. So basically, pre-threshold is any stage if there is a plus, and even without a plus, if it is stage 3, you are going to require to treat these patients. So to prevent blindness, what was identified over the years is you need to treat pre-threshold, not when the threshold is reached. So type 1 ROP, pre-threshold ROP has to be treated. Type 2 ROP, which is all their stages which are not in type 1, you can do a weekly follow-up. If they convert into a type 1 is when you treat. So how do we treat these children? Earlier, when ROP treatment started, it was with cryotherapy. And it worked quite effectively well, but cryotherapy is more cumbersome with bigger machines, now almost obsolete. And post treatment inflammation, pain was very much, and therefore there were a lot of exudative retinal detachments also happening when cryotherapy was there. But yeah, the gold standard is laser photocoagulation. What we need to do is ablate entire avascular retina. Like I told you, there is a fight between this avascular, which is hungry retina, and the vascular, which is the developed retina. You have to kill the hungry here. And if you don't kill the hungry, the demand for vascularization is going to keep happening, and therefore the ROP is going to keep progressing, come what may. So ablating the entire avascular retina, not leaving any skip area, is your goal. Diode laser is used, but argon laser can also be used. And these are more for ophthalmologists to see here, where these are the settings that you keep. Normally, if a child has zone 2 or zone 1 ROP, you might require 4,000, even 6,000 spots. And if I convert that into time, usually 3 hours. So along with the rest period given to the child, it might take 2 to 3 hours for you to finish both eyes laser treatment. Now, if it is, say, zone 2 anterior, might take little lesser spots, like maybe 15,000, 1,500, 1,000 to 1,500 spots, which might take lesser time. Now, for the pediatricians on the forum, this is done under topical anesthesia, which means we are going to use only eye drops to anesthetize the eye. We do not need general anesthesia in most of the settings in our country. We just need the child to be fed in between, and we keep the child like it is shown here. This is from Dr. Subhadra Jalali's article, where she is shown really how to hold the face, how to stabilize the face, and how to make sure you're not indenting too much. So if you're pressing the eyeball too much, that again can cause increased vitreous pressure and cause bleeding in the eye. And the eye will look red and swollen after the laser treatment is done. This might last for almost a week. Eye drops will be given for the same. But this is how it is going to look. These are how the laser spots actually look when we see from inside. And you see the entire avascular part here is nicely lasered. What can happen, of course, laser does not go without complications. It can lead to myopia in the, we see very high myopes, like -10, -12 myopia coming in these premature lasered ROP babies. They might have asymmetry between two eyes. One eye would have lesser ROP, not requiring laser. One eye would have required laser. And this asymmetry can cause lazy eye or amblyopia also. Intravitreal bevacizumab or Avastin, like we all know, is definitely very good for zone 1 ROP. Now, zone 1 is where the disc and macula are there, and if we are lasering there, we are seeing a lot of visual difficulties in these children. And Avastin, that is anti-VEGF. So like we saw in the etiology, VEGF is actually the one which is increasing in your second phase and causing vasoproliferation. So if we are able to tackle the VEGF at that point, we are actually preventing severe vasoproliferation and complications. So especially in aggressive posterior ROP, or if there is, there is zone 1 ROP happening, those are the babies where Avastin really does the wonder. Many a times only single injection is required and the ROP regresses beautifully. It buys time. Sometimes it buys time for laser. If your pupil is very small, cornea is very hazy, you are hardly able to see anything because of the rubiosis of the iris, then those are the ones where after giving Avastin, there's nice dilatation and you can then do your laser very well. Lesser treatment area will be required for the laser, and therefore lesser post complications as the child grows up. So there are good studies, beat ROP, block ROP studies have published the data very well. 0.625 Avastin has to be given single injection, both the eyes. So this can be done in the NICU itself. We don't need to shift the child into general anesthesia or OT at all. Again, these are reiterating the treatment guidelines where I told you zone 1, stage 3, you treat. Zone 1 with plus disease, any stage you treat. And zone 2, if you do not have a plus, everything you can follow up. But zone 2, if you have a plus and if you have stage 2, 3, you're going to treat. So this guideline As you do ROP more and more, you understand the treatment guidelines more. Now, till when do I continue to screen the child? Now, a child, one is, of course, if you have a mature retina, completed vascularization, stop screening. Second is if you are seeing zone 3 vascularization, but there has been no previous zone 1, zone 2 disease, only zone 3 immaturity is there. And you have seen in 2 visits that it is still immature, you can stop screening. Regression of ROP, if very good regression post-Avastin, post-laser has happened, then these bigger children, once the child has become big, you can stop screening for ROP. And a post-menstrual age of 45 weeks, no pre-threshold disease or worse ROP, these are the children where you can stop screening. But according to pediatric ophthalmologist, there are a lot of things here where can I predict ROP? Like, can you as neonatologist predict which baby of yours can get high ROP? Now, as we know, gestational age and birth weight, all of us know. But are there some factors? So there are some things which have now come into weight. One is the low weight gain proportion. Weight at 6 weeks minus the birth weight divided by the birth weight. Now, this ratio, if it is less than 50%, these are the babies who are considered as high risk for ROP. These are the ones where you can get them screened at 2 weeks, 3 weeks itself, and get your ophthalmologist to come every week to check these babies. Then there is Windrop program which happened, and this found out that they did weekly monitoring of baby weight and IGF-1 levels from birth to 36 weeks. And it had such good sensitivity, 80 to 100% sensitivity in predicting ROP. So IGF-1 levels can also be thought about monitoring. ROP score. Now, this score was made from birth weight, weight gain, gestational age, and blood transfusion. And there is a scoring system. When in this first 6 weeks of life, if we put the score, we have a high predictability of ROP. There are also being studied biochemical tools where they have found that E-selectin levels actually increase in the second phase of ROP. So if we see E-selectin levels increases 10 nanogram per ml, then these have higher risk of ROP. According to a pediatric ophthalmologist, there is a lifelong follow-up of these children because most of them end up with having refractive errors. If post-laser, they can have cataracts, they can have retinal issues like retinoschisis or retinal detachments or exudative retinal detachments. They can also get strabismus. These are the children who are premature babies anyways have a higher risk of squint or strabismus. Cortical visual impairment because of periventricular leukomalacia and amblyopia. So a lot of other things also we see, even sometimes this partially treated retina having this kind of a cicatricial retinal disease called drag disc is also seen, and these are the ones which have poor central fixation, squint, eccentric fixation, strabismus, and high myopia. So these are the patients where they require refractive correction also. So this is again concised guideline which was made operational guidelines for ROP in India. You can go through this. Whom do we screen? When do we screen? What are the screening methods? Where is screening to be done? How will you take your management decision? And how are you going to communicate and document? Is all nicely given in this guidelines. These are my references. Those interested can definitely go through this. Here I would like to complete the session, and we can take some questions if needed.
Excuse me, ma'am. PPT over, ma'am. Hello, ma'am.
Yeah.
Ma'am, session completed?
Yes.
Okay, ma'am. Ma'am, please log out from Zoom.
Yeah, I'll do that.